Pittsburgh, for that kind introduction. It's really a pleasure to be here. My name is Raquel Watkins. I'm a board-certified allergist, and I practice here in Jacksonville with the Boiling River Clinic. I also have a Master of Science in Clinical Epidemiology. You know, they say over the course of your life you make lots of decisions, a few key critical ones, and I think for me, it's really been a good thing. I really enjoy allergy immunology, and I'm excited to share with you this topic of are food allergies real? So this is the roadmap for today. I thought I would touch briefly on some definitions, talk about the prevalence and natural history of this condition, review one or two clinical presentations, talk about future approaches and the role of the allergist. How can an allergist help you as you handle patients who have food allergies? So this is, I think, a really important topic because food allergies affect both children and adults. And from an epidemiologic standpoint, we think of food allergies as the second wave of an atopic epidemic. In other words, if you think about it, allergy shots have been out for 100 years. We feel that we have a good grasp, sort of, on why a person might have asthma or even inhalant allergies. But it's only since the 1990s that we've noticed a swift increase in the prevalence and the cases of food allergies. We really didn't hear a whole lot about it until then. So we are struggling in allergy to understand why we're seeing the second wave of this atopic epidemic. But I'll share with you some thoughts on why that might be. So it's become a huge issue in the medical world, food allergies. So much so that the National Institute of Allergy and Infectious Diseases in 2010 published a consensus guideline. And if you haven't seen it, I think it's worth taking a look at. There is a patient version and a physician version. And they did this because, number one, we've seen this increase in incidence prevalence of food allergies. We've heard about people, you know, I'm sure most of you in the room have heard of the child in California who died this summer from the Rice Krispie treat. Also, there's a public misconception about how common this is. You know, they survey the public, and the public believes that about 25% of people have a food allergy. And clearly that's an overestimation, but it hurts, I think, people who truly have a food allergy because you minimize their issues, sort of, when probably you should be paying keen attention to them. In addition, what the NIAID found was that there is a lot of variability in how we as physicians handle food allergies. So because of all that, they said, let's come up with a set of guidelines, consensus statements, let's talk about it. And so I'll start off or talk with their definition because I think this is key. And I share this with patients when they come in. A food allergy is an adverse health effect arising from a specific immune response. It occurs reproducibly on exposure to a given food. So by definition, a food allergy is immune mediated. Your immune system has got to be involved. So when a patient comes in with symptoms and their concerns about a food allergy, I will often draw this out on the exam table. You know, I listen, I get their history, and then I back up and I say, you know, Mrs. Jones, you are describing an adverse reaction to a food. And what we really need to figure out here is if we're dealing with your immune system or if this is non-immune mediated. Because if it's your immune system, then we can both move forward saying you do have a food allergy and we need to take some aggressive measures in some cases, versus over here, I'm not discounting your symptoms, but clearly, this is not an all-inclusive list either, but you know, you are a little different if caffeine is causing your abdominal discomfort, or if it's a lactose deficiency, or if it's reflux, than if you have an immune-mediated problem. And furthermore, if it's immune-mediated, we have to drill down even deeper and determine whether or not it's IgE-mediated, is it mixed, or is it non-IgE-mediated. So let me just review. If we're dealing with an immune system-mediated adverse food reaction that's IgE-mediated, as you can see, it's highlighted in red, this is one of the more serious in terms of life-threatening immediate reactions that can occur when you ingest a food. And you can see anaphylaxis, a systemic reaction that can result in shock or death, or you can see more cutaneous findings, urticaria, swelling of the throat, face, lips, tongue, or vomiting, or even isolated respiratory symptoms after ingestion of the food, such as bronchospasm. You can also see mixed reactions, and atopic dermatitis is an excellent example of a mixed reaction. In other words, when patients who have atopic dermatitis have a little bit of an IgE-mediated trigger that's exacerbating their skin related to foods, and then they also have other issues. So for example, they've done a lot of studies at National Jewish in Colorado, and they've determined that people with atopic dermatitis have a loss of function mutation that's causing a problem in a protein called filaggrin. It helps with the integrity of the skin. So you're missing a crucial protein. It's not working well. So the integrity of your skin is going to be affected. In addition, those patients also have a problem with thymic stromal lymphopoietin, which helps with promoting pro-inflammatory markers and causing irritation to the skin. So they clearly have a structural, functional problem with their skin. In addition, foods can exacerbate their skin. So you want to educate your patient with atopic dermatitis that, okay, let's skin test you or blood test you to foods. If we find something and it makes clinical sense, you're eating it and you've noticed your skin's getting worse, then we're going to withdraw that food, but your skin may not completely normalize. We're going to have to take some measures to restore the barrier of the skin because of the protein problem with filaggrin and whatnot. Over here, I know Dr. Foodie's already covered celiac, but that would be more of a non-IgE-mediated immune food allergy. All right, let's talk a little bit about when would you think that it's immune-mediated versus not? So this case, a 27-year-old who was treated in the ER about 6 weeks ago for generalized urticaria or itching of his throat, abdominal cramps and pain, tightening of his throat, and dizziness. The episode occurred while he was running outdoors for 20 minutes. He began his run shortly after eating celery sticks, cream cheese, apple juice, and peanut butter. And he's eaten these products many, many times before without problems. He usually exercises outdoors after lunch and has noted mild itching in the past, but really cannot recall what he had for lunch on those occasions. So I see quite a few young children, teenagers, runners, they exercise, and I mean, I don't have a lot of these patients, but this is a clinical scenario that I hear enough that I thought I would share with you. So this patient, when he's telling me his story, or his parent telling me the story, this is a 27-year-old, but when he's telling me the story, I'm keying in on the itching, because one of the hallmarks of atopy is itching. One of the first things I learned in training, even I was an internist, you go through extensive, you guys know, you go through all this stuff and you're like, oh, the ICU vent and the settings, and then I show up for fellowship. They don't even care about that. They're like, there's a patient itchy? What's wrong with their skin? Nobody wants to know about all the other fancy stuff. I mean, my preceptors, right? Because they're more concerned about the allergic or the atopic part of it. So itching is key, and you want to really get the patient to describe for you what's going on. And some young women will even say it feels as if they're going to start their menses, they're having abdominal cramps or that kind of pain. But these are all signs and symptoms of an allergic reaction. And if you go to those guidelines that I mentioned briefly, they have a great table in there. This is, obviously we're not going to go through each of these, but I wanted to show you that pruritus is mentioned quite often in the immediate symptom, but a lot of other things can happen. Someone can, kids will sort of, I don't know how many of you have children, but they'll scratch their throat, they'll make that cluck kind of sound. They're trying to describe for you what they're feeling back here. And the worst scenario is, we administer allergen immunotherapy, and if a patient says, I just feel like I'm going to collapse, or I just felt like I was about to pass out, it's been well reported that a sense of impending doom, you probably, if you think they're about to have an allergic reaction, you should activate epinephrine and whatnot. You shouldn't wait for them to sort of collapse. But all of these things, all of these symptoms would help me as a clinician to say, you know what, this sounds immune-mediated, and I should probably be thinking how I'm going to sort that out for that patient. All right, so let's talk a little bit then about what happens in food-induced anaphylaxis. It's important to remember that it can be rapid in onset. It involves multiple systems. It can. So a patient can have cutaneous symptoms, respiratory, GI, they can be vomiting. All of these things can happen all at the same time, and it's potentially fatal. As I mentioned, there was in the summer of this year, a little girl, I didn't care for her, obviously, she's in California, but we all saw that on the news. This can happen, it's real for some people. And we have to take it seriously for that percentage of folks. Within a few minutes to several hours after exposure, you can see symptoms. It can be biphasic, and I think this is really an important concept here. So when you are having an allergic reaction, the first thing that happens is that your mast cell with its IgE receptors attaches to whatever this trigger is, and the mast cell basically disintegrates, releases histamine. So you see the itching and the discomfort in the back of the throat, the respiratory problems related primarily initially to histamine release. But remember that mast cell has also sent out cytokines and other chemicals that are recruiting help. So it's a basophilic response. They're recruiting basophils to show up to help out, because clearly they realize they're overwhelmed. They're overreacting to a normal trigger, but they are sending signals to recruit some help. So this is important, because if you really think someone is having food-induced anaphylaxis, the first-line therapy is epinephrine. When you give Benadryl early on, you calm things, the histamine response, but you have not stopped this late response. And you can be surprised later. In a few minutes to hours, the patient can present again, say, I'm still itchy, I'm hivey, and even collapse on you because you've done nothing to treat the second wave, the basophilic response that's coming. So it's important to remember that 20% of people can have a biphasic response. If you treat someone in your office for anaphylaxis, you gave them epi, you gave them Claritin, prednisone, you watched them, you sent them home, they call you back, doc, I feel it's happening again. It could be. You shouldn't discount that, and that's why we dispense 2 packs of epi, and we recommend you keep the 2-pack together, because you might need that second one. All right, we'll go over that in a little more detail later, but it's another point is that sometimes beta tryptase is not going to be elevated. As you know, tryptase is elevated in anaphylaxis. It can be, but it's short-lived. So sometimes you'll miss it, so you can't rely on that as proof positive that anaphylaxis occurred. Any food can cause food-induced anaphylaxis, but the highest risk are peanuts and tree nuts. And risk factors for fatalities are delayed administration of epinephrine. In my training, and I still practice this clinically, epinephrine, if you think it's a food-induced anaphylaxis, or if you think you're dealing with anaphylaxis, epinephrine should be given early and often. It's a 2-pack, it's dispensed together. We dispense a 2-pack plus a refill, and it should be kept together. So you want to give it early, don't wait, if you truly think you're dealing with anaphylaxis. Young adults and teenagers are high risk just because they're teenagers and they're young adults and they feel like nothing bad can happen. They're no longer under their parental supervision as aggressively, and they take chances. They'll eat things that they know they shouldn't just to fit in, perhaps. They won't carry their epi as they're supposed to. If you have underlying asthma, this puts you at risk as well, because if you're having anaphylaxis and then you end up having a flare of your asthma at the same time, you're dealing with 2 problems, especially in children. That's not a good mix at all. And then, interestingly, if you don't see any skin findings, if, say, for example, you have someone that is allergic to peanut, and they ate some peanuts, and you don't see any skin findings, but they tell you, I don't feel well, just don't feel well, you should consider giving epi, because that is associated with fatalities as well. And I think of it as they sort of fast forward through, it's this impending sense of doom, things are happening very quickly, and you're going to end up with cardiovascular collapse is what's evolving, sort of. So these are some risk factors for fatalities that I think are worth keeping in mind. So let's talk about the case we just reviewed. Which of the following would be the first step to establish the most likely diagnosis? Give a food challenge to peanut in the office? Probably not. You don't do that right off. that we usually skin test or blood test first to have to see where we are, sort of, is this person likely allergic or not, before we move forward to any food challenges. And food challenges should be done in a supervised setting. You should be equipped and ready to treat anaphylaxis. In our clinic, we use the Duke protocol, where you start off with a graded challenge, and if you can ingest 10 grams over the course of gradual observation, one-on-one nursing, IVs hooked up, and you tolerate that, then you're not allergic. So it's a lot more complex than it looks, but we never start off with that. Consider either ordering serology to celery, apple, milk, peanut, or wheat, or sending to an allergist to prick test to these foods. That's probably the best answer. Going down to the next one, send the serum tryptase, unlikely to be helpful. And then do its spirometry before and after exercise, unlikely to be helpful. This patient that I described has food-dependent, exercise-induced anaphylaxis. So we think that exercise does something to the gut barrier. It makes it leaky, perhaps. So when you eat, and we see this a lot in, these foods, I don't really run that much and all this other stuff. So, but I think that peanut and soy and all this, athletes, they load on that, I guess, before. So I think any food, if they started to load on something else, I guess, maybe we would see them popping up. But these seem to be more common in that group. So that's why we see them so often here as the trigger foods. So what's happening is they eat the food and then they exercise, the gut gets leaky, the food presents to your immune system looking a little differently because the gut's leaky, and then the immune system is overreacting now to this food. So these patients, we recommend that you exercise first thing in the morning before eating, or you exercise indoors with an EpiPen. In case something were to happen, someone else would be around. And then we would not do spirometry before and after exercise for this patient, even though we're worried about exercise as a trigger. If we really wanted to kind of confirm it, you would skin test them or blood test them. If these foods up here were negative, then you would give them the food and get them on a treadmill within 20 minutes to see what happens. Now, clinically, we rarely ever do that, because that's, what if they die? I mean, we just don't do that. So, but you could potentially in a research study, try to do something like that. But we typically, if I test them and they're negative, I say, listen, you're not really allergic to these foods, so in a non-exercise setting, go ahead and eat them, but don't eat them before you exercise. I hope that makes sense to you. All right, so when should food allergy be suspected? In individuals with antecedent food ingestion who present with anaphylaxis, or any of the combination of symptoms listed earlier on that the table I showed you from the guidelines. If you have an adult who's been diagnosed with eosinophilic esophagitis, you should think about a food allergy. And if you're dealing with infants, young children, and suspected older children with atopic dermatitis or any of these conditions, you should consider evaluating them for a IgE-mediated food allergy. Now let's transition to the prevalence of food allergies. So as I mentioned earlier, the public perception is that about 25% of people have a food allergy, but this is an overestimation. In America, 5% of children have a true IgE-mediated food allergy, and cow's milk and eggs are the more common triggers. In adults in America, shellfish is more common, and about 3 to 4% of American adults have a true IgE-mediated food allergy. This is a global problem. About 250 million people have a food allergy or problems with foods. And so in Australia, they recently published a report. They did something that I thought was pretty gutsy. They skin tested 1-year-olds. They had 5,000 1-year-olds enrolled, and they skin tested them. And they found that about 1 in 5 of them had a positive test to foods. So, as you know, a positive skin test or blood test doesn't mean you're allergic, but they wanted to determine if these children were truly allergic. So they gave these 1-year-olds the foods to which they tested positive, and they wanted to see who would have a clinical reaction. And they found that about half of them did. So their prevalence, they're estimating about 10% of their children have a true food allergy, which is a pretty high, in America we're at 5%, but it's just an indication that something's a little different, what we're doing. We're not exactly sure what, but there are more and more children who are presenting with food allergies, a true food allergy. All right, so let's drill down then. Often in a clinical scenario, patients will present with a problem, sort of. So they come in and they give a history that they had anaphylaxis or atopic dermatitis. And then the question that comes up is, well, geez, could this be food driven? And if a patient presents with anaphylaxis, if you're a child, 1/3 to 2/3 tend to have food as a trigger. So you should consider testing to foods. Not as common in adults, but still, when I have a patient that's sent to me secondary to, okay, they had anaphylaxis, they're not quite sure what happened, but I always try to get a good food history, and I do test those folks more liberally than I would typically, because I'm worried that I don't want to miss a true food trigger here. We've already talked about atopic dermatitis. As I mentioned, it's a mixed disorder, so we have to think about food triggers in those patients. In acute urticaria, which is usually present for less than 6 weeks, about 1 in 5 will have a food trigger. Once you have urticaria or hives for over 6 weeks, it's really, really hard to find a trigger. Only about 4% of children may have a food trigger, and I usually don't test the foods if it's chronic urticaria, because it's just really unlikely you're going to find an answer, unless the history really is driving that, yes, it's a food, then I won't do a random test to foods. Asthma, if you're dealing with an asthmatic and you have tried just about everything, you feel the patient's compliant, you have them on good medicines, and they're still having exacerbations, then especially if you're dealing with a child, you should think about testing them to foods. And I'm sure the gastroenterologists in the room have more information on this than I do, but in my recent CME a couple weeks ago, wheat and milk seem to be leading in terms of children and adults as potential triggers. All right, so what's the natural history? Because this question comes up a lot. So we've diagnosed a patient with a food allergy. What does that mean for them? Well, about 80% of children who have a cow's milk, soy, egg, or wheat allergy will lose that allergy by their teenage years. They'll outgrow it, so that's good news. When I was in training, which wasn't that long ago, we used to teach that they would lose it by 1st grade, but for whatever reason, we think perhaps this absolute avoidance or hygiene, we're so clean, kids tend to hold on to this allergy more, but good news is eventually they may lose this one. As compared to this last bullet down here, very few people outgrow peanut or tree nut allergies. We used to not test too much after we made a diagnosis because we thought you're not going to outgrow it, so why should we reevaluate? But for the 20% of people that do outgrow peanut allergy, it's important to know because not that they're going to consume peanuts subsequently, but at least they might lessen their anxiety when they're out eating if they have an accidental ingestion. So we do recommend checking this, repeating checks for a while at least to see if they've outgrown it. Up here, fish and shellfish are typically lifelong, so you have to just avoid that for the rest of your life. All right, so what makes a food allergenic? Why are on the slide I showed you earlier on with the prevalence, there are 8 common food allergens. Why are those 8 so common? So those would be fish, shellfish, peanuts, tree nuts, wheat, eggs, milk, and soy. So this is probably why those kind of are always on the forefront. A food allergen can be either class 1 or class 2. Class 1 food allergens are water soluble. They are about between 10 to 70 kilodaltons, so they fit very nicely into the IgE receptor. They can get in there and then your immune system gets a chance to say, I don't like you. So they fit quite nicely in the groove. And then they are also resistant to heat, acid, and proteases, and you are sensitized by them through the GI system. Examples, as I mentioned, would be cow's milk, chicken egg white, or albumin, peanut, and these are the various proteins that are allergenic in peanut, and wheat. We are looking at studies now. You know, sometimes people will say to me, okay, I'm allergic to peanut. How allergic? Can it kill me? And I have to say, listen, based on your history, you didn't die the first time, but I'm testing you. You're telling me that you swelled up, all these things happened. I'm thinking it's your immune system. I tested you, it correlates. You have to avoid it. And they say, well, okay, I'm going to try, but if I accidentally ingest it, will I die? I don't know. You just have to avoid it and keep your EpiPen. But we're now looking, that's a good question though, you know, how careful should I be? And so they're looking at studies now to see whether or not, if you are sensitized to a specific component, say for example of peanut, if say you're sensitized to ARA-H3, that component, does that confer a morbidity or a mortality? And so we're not quite there yet, but I think testing to foods is going to become more specialized. It's not just going to be a prick tested peanut or a blood tested peanut, but perhaps to the components, and then we'll see if you are a component this or that, then that confers more, you know, problems, and those people should perhaps more aggressively avoid it, but we're not there yet. Moving over to this side here, so class 2 food allergens are plant-derived. They are highly homologous to pollen, highly heat labile, and you're sensitized to them through the respiratory tract. So let me explain. I'll give a clinical scenario. So birch tree pollen, BET-V1, is homologous or similar to the protein in apple, carrot, and celery. We'll just use that. So a patient comes in, and usually these patients have been struggling with this for a while, and typically they come in with someone else. They never present alone because they're going to tell me a story they think that I won't believe. They say, listen doc, I know I have bad pollen allergies in the spring. I've always known that, and I really don't need you to test me. I know that. My nose is runny and stuffy. But here's what's been happening over the years. When I eat raw apple or fresh apple, carrots or celery, my mouth itches. I feel as if my throat is going to close off. I don't get any runny nose or anything, but I feel sick to my stomach, and I really have a lot of itching of my palate. So these patients, and I say, okay, and I tell them, you know what? You have oral allergy syndrome. You are really allergic to birch pollen. Your immune system, when you breathe in birch, the mast cell releases histamine. It doesn't like it. And over the years, you've made a lot of antibodies to birch. But there's only so much birch out there. I mean, now we don't have that much birch in the fall, but you still have those antibodies. So when you eat these foods, because they're homologous to BET-V1, your immune system looks at that apple at MAL-D1 and says, you look like BET-V1, I'm going to destroy you. And so you end up with the oral allergy symptoms in your mouth. So this, you know, these patients, basically, they can eat cooked food. They can eat the cooked apple, cooked carrots, but they can't eat it raw, because when you cook it, it's destroyed. The heat destroys it. And so the protein doesn't look the same to the immune system anymore, so you don't have those symptoms. So this too is important to remember. Those patients are falling over here as opposed to these, you know, this classic situation over here. It's important to validate that for those patients, to help them to understand, no, you're not crazy, but this is something that your immune system is doing, and they have to absolutely avoid the food fresh. Now, let's talk a little bit about why are we seeing this increase in prevalence in food allergies. Because the normal response is to be tolerant, right? Your GI system is there for a reason. We eat, that's how we sustain ourselves. So why then are we seeing food allergies? So the hypothesis, there are a lot, if you Google this, you'll find a lot of things online. But the hypothesis that has held up over time is the hygiene hypothesis. I'll review that in a minute. We think that some other reasons why we may be seeing an increase in food allergies and loss of tolerance is that we are able to deliver and sustain more premature children because of technology. And a premature child has an immature gut. Okay, so it's not going to be able to do some of the things that a mature gut can. And so when we feed them, are we setting them up to develop sensitization to foods? Perhaps. We don't know for sure. These are hypotheses. I've already talked about exercise as a factor that can increase the intestinal permeability. Other things, NSAIDs, alcohol, and infections can do that too. And then the hygiene hypothesis speculates that we are too clean. In other words, by the hand sanitizer, obviously we should wash our hands between patients, that's different. But outdoors, when we're dealing with our children and growing up, it seems that, you know, we're very fixated in general in Western society in washing hands and just the sanitizers and all this. And maybe that is affecting how the immune system is developing. It's not being able to develop as it should, because years ago, we didn't have all those things, and your immune system just fought it out, okay? It dealt with it, and it matured as it should, perhaps, and now we're seeing something different. They're even wondering, and this is a hypothesis, these folks here outlined in their work that maybe because there's also been a rise in C-section deliveries, that perhaps there's something to being delivered vaginally and exposure to endogenous bacteria that affects how your T cells develop as well. These are hypotheses. Obviously, have children as you wish and whatnot. These are just hypotheses, okay, as to why in the past 20 years we've seen this weird shift in more food allergies. Something to think about and research. All right, I'm going to skip eosinophilic esophagitis and move on to history. I would say that perhaps one of the most helpful things is your history. When I graduated from fellowship, the Academy for Allergy Immunology, they have a workshop for for people just out. And one of the things that stuck with me when I went to my session was there was a senior physician there who said, I want to tell you guys something. You learned a lot in training. Stick to what you learned. Don't be swayed because you're young, you're not feeling confident, you're not sure about your abilities, but here's a story. And what he told me was, what he told all of us was that he was involved in a case where a little child had gone to a birthday party and had anaphylaxis. 911, EMS to the emergency room. And the child came to see him for testing, and he wanted to get a good history. And he said, Mom, tell me, what happened at the birthday party? And Mom says, it's peanuts, testing to peanuts. Tell me what happened, please. Give me some history. What happened? She refused to. He said, I'm not going to test into peanuts because you're not giving me a history. Mom got upset. She left. He documented all that. The interview ended. Okay. Later on, he got this request for records, and he was like, okay. He later found out, because it's a small community he was from, that the mother went to another allergist, all right, and got tested for peanuts. Peanuts were positive. We all know that just because you're positive, you need a history, okay? Just because you're sensitized, I told you about the Australian story, just because you're sensitized doesn't mean you're truly allergic. We need a history. Well, the child apparently went to other birthday parties over the, he's growing up, and had another event which was pretty life-threatening. And so Mom even started to wonder, well, he didn't have peanuts this time because she was really aggressive avoiding it. What's the trigger? Well, ultimately, the history revealed that this child had an allergy to latex. And so balloons and all this stuff. And so I remember that, and I think sometimes when I meet patients, I don't tell them that story because, what's the point? But I say, listen, you have to help me. You play a role in this. You've got to tell me your story. I'm not here to just put pricks on your back. You have to tell me, help me to help you by sharing with me your story about your recollection of what happened. And I will document that, and I will try to help you to sort through it. But we work together. A test does not tell me what you're allergic to. You sort of help me to determine that. So I would share with you that history is really important. Sometimes I'll get a lab sheet with a lot of things, because with the blood you run panels. With skin tests you can do an individual test. And so I'll get panels and I'll say, listen, did you eat this? Are you doing okay with this? Yes. So then we don't need to really test for that or avoid that because they're eating it and they're doing okay. So you want to really go through the history and try to understand if there's a real correlation. Going on down here, you want to get some information on treatment, outcome, exercise, medications. You want to talk about diet details, can you recall what's going on? Write it out for me. And then you want to look on their exam, and then I pull those slides up in my head. Are you falling over here into immune-mediated or non-immune-mediated? And then if you're immune-mediated, are you IgE versus other? Okay? So that's kind of how we approach this, and history is really, really critical. And I think as we work together with my patients, they begin to realize that, it's kind of important to know the history. It's not just we test everything, and that's, really critical. Panels, as the guidelines recommend, that broad-based panels should not be done without supporting history because you worry about false positives. Oral challenges are the gold standard. We can move to that if we feel we need to for a definitive diagnosis. If it's non-IgE mediated, you want to consider biopsy of the gut. And then you want to recommend other things if you suspect it's non-immune mediated. And I'm sure Dr. Fawdy kind of went over some things with celiac regarding non-immune mediated, immune mediated but not IgE. All right. I think we talked a little bit about skin tests. No test is 100%. We need a good confirmatory history. And then, let's see, these are unproven experimental tests, which are not valid. We don't put a whole bunch of credence on IgG to foods. Sometimes that's run, but there's no data to support that that will help you in making a diagnosis. So we don't give that much, credence, I guess. Management, you want to avoid the specific food trigger. You want to ensure that nutritional needs are being met, especially if you're dealing with a child. You want to encourage mom or dad to work with a dietitian or nutritionist so that their nutrition stays on target. Education is key. There are 2 injectable epinephrine devices out there, and you want to give out a food allergy action plan and review with the patient, one or the other device. So that they are aware of how to use it should they have a true allergic reaction. All right, in terms of prevention, I don't have a slide on this, but I think it's important to think through how you counsel patients who have true food allergies. So for example, peanut. If you have a child with a peanut allergy, 7% chance a sibling is going to have a peanut allergy. In general though, we don't recommend maternal elimination diets. It's too risky. We say eat healthy, mom, so that your baby can, do well. And peanuts, a little different. If you have a child already, we may want to withhold that early sensitization. Perhaps we're not sure where to go with that, but in general, we don't recommend that mother eliminate anything. We also recommend introductory, along with pediatrics, introductory of complementary foods at 4 to 6 months. And to introduce those highly allergenic foods as well, aside from peanut, as you would after they do, fruits and vegetables and whatnot. Let's see, any other prevention things? I think those are the newer things that have just come out. Oral immunotherapy is evolving. They're doing a lot of studies on this to see whether or not gradual ingestion of a food that you're allergic to in a control setting will lead to tolerance. But I don't think this is ready for prime time yet. It's still investigational, and there's some concern that you might actually promote other diseases by doing the oral immunotherapy. So it's not ready for clinical practice as yet. There's some work being done with Chinese herbal medication, it looks promising, but again, not quite ready for prime time yet. So I will close with saying that as an allergist, we can work closely with primary care physicians to help or food allergic patients in terms of the initial diagnosis, single food diets versus multiple, and talking a little bit about prevention of natural history. And I'll stop there. That's a great question. The question is, when should we introduce solid foods? I I wish I had an answer for you. There are currently 8 randomized controlled trials going on to answer this question. There are 2 big ones going on in Australia, and with a particular egg. So they have to do each food separately, as you can imagine. So there's a lot of trials going on right now, and you are absolutely, so there's concern that actually we should not withhold. That withhold an introduction, and obviously do not put this into practice. This is all, they're looking at this, but withholding the food may help to encourage this intolerance that perhaps we should be introducing earlier. Or in some patients who we introduce early and they have anaphylaxis, when did they become sensitized? They're backing up to say, is it in utero? When does the sensitization occur? And they're not sure. So I don't have an answer for you, but I think these 8 randomized trials are evolving, and we're going to get some answers that might help us and help our patients in